all of you, and welcome to the GMO Academic Hour program. Today's topic is wound management at primary care settings. The resource person for today's lecture is Dr. Gayan Ekanayake. He is the consultant plastic surgeon attached to National Hospital of Sri Lanka. Dr. Gayan Ekanayake was graduated from Faculty of Medicine, University of Peradeniya in year 2001 and was board certified as a plastic surgeon in year 2010. Dr. Ekanayake has served as a consultant in teaching hospitals Karapitiya, Anuradhapura and Kurunegala. He has held the post of Secretary, College of Surgeons of Sri Lanka and Sri Lanka Association of Cleft Lip, Palate and Craniofacial Anomalies in 2020. He has co-authored several books and also serves as an external lecturer for the Faculty of Medicine, University of Colombo. Dr. Ekanayake is an examiner for MD surgery exam and member in the specialty board of plastic surgery. Further, he is a council member of College of Surgeons in Sri Lanka since 2016. Further, he is a council member of College of Surgeons Sri Lanka since 2016. He also is a visiting lecturer at University of Wayamba and Peradeniya. So let's warmly welcome Dr. Gayan Ekanayake to the GMI Academic Hour program. And if you have any questions related to wound management, please send them over through the chat box. We can discuss that at the end of the lecture. Let's listen to Dr. Gayan.
I hope you can see the slides and very warm greetings from National Hospital Plastic Surgery Unit, where we are dedicated 24-hour service, and it's been happening for nearly 52 years now. So we are going to share some of the important current knowledge in wound care. So I named this talk as Science of Wound Care because you will realize that science has evolved a lot, but it still adheres to the basics. And without knowing basics or refreshing basics, it's like it's unlikely to get a better result because you will be a technician rather than a doctor. So if you don't know the basis of what you're doing, and also you can improve on your practice as well as patient care at the end, and so the end result would be much better wound care for those who need treatment under you. So let me take you through your undergraduate career. You see that wounds are there, and you need to know what is a wound. Basically, wound is not an ulcer. Ulcer is one type of wound. So there are so many wounds. If you say wound, they can be defined as disruption of the skin, mucous membrane, or even organ tissue. So there are about 6 basic types of wounds that you see. They start from abrasions, excoriations, skin tears, avulsions, lacerations, and punctures. So these are different types of wounds that you will get, and it's very important that you recognize the wound when at your primary care. Or there are two areas that is actually important for the patient management, as well as there's medical legal implication of all these wounds. And if you say tear instead of abrasion, so then there's a technicality is different, where the wound occurs in a different manner. So then these things are important when you talk about, because if you do something and the wound nature changes when there's a medical legal person sees the wound, and he might not get the proper picture of what has happened before the wound has occurred. It may be assault, and if you say abrasion with the assault with a sharp weapon, so it doesn't tally, and it might say that the person actually fell down and got an abrasion rather than an assault. So I'm sure you you get my point there. And abrasion is basically a sharing of skin by a rough surface. And these are, if you see different types of abrasions when you go into a area room where there's a rough wall and you hit against that, you get your skin might get peeled off. So this is a common abrasion. But when we have road traffic accidents and the patient just gets dragged on on the road, those are actually friction burns. So abrasions, they are abrasions, but the mechanism is a friction burn. So they have friction and a burn component. So there's a different, technically there are a little bit of difference between just a simple abrasion and a friction burn, because it behaves like a burn rather than just simple abrasion. So simple abrasions will just heal without any problem, but the grace sort of when patient has a burn, it undergoes a certain amount of necrosis and then burn reaction on the surface. So it's I'm sure that you have understood this basic difference between these two types of abrasions. Now, excoriation is that something like we call it a scratch, cat scratches and those sort type of different scratches. So those are different, and actually these are important medical legally. So I'm sure the people who are actually in the medical legal practice will tell you the direction of scratch and all those things are important when you build up a case against some assailant who has done something wrong. So these are not really lacerations; they are excoriations, and it's important to note the direction and the what has happened to the wound. So these are important in primary care level, where you might see these as in certain, you should not miss these things, especially in child abuse and even sexual assaults. Now, skin tears are something that we come across frequently, where any blunt force that is causing a tear in the skin rather than a laceration. That means it's not a laceration; it's a tear. So there's sometimes you get no skin loss. It's just a tear, and you can just bring it together and actually suture and finish off. But when there's skin loss, partial skin loss, then you might need to reposition some of the tissues to cover that wound. Of course, when there's a total flap loss, you might need to do more additional things. So your limit, what to do and what not to do in these three types. So it's very easy to have your plan. So whether you are going to manage it or somebody else needs to be managing these things, you can make the call very quickly. Now, the avulsions are another thing that we call degloving injuries. You will see them on and off, especially when you get tires, person falling under a tire where the tire tries to stops, but still the skin gets caught up in the tire and just gets removed. The other type of avulsion is that you get hair caught in a wheel and getting pulled out. So we'll see some of the cases later on. Now, the laceration, we have seen that lacerations, actually surgical incision is also a sort of a laceration. I mean, if we do it, it's a surgical laceration. If someone assailant does it, and it's a cut and somebody. And also there are blunt injuries can also cause a laceration, but there are actually where the things are actually falling apart and it doesn't come together. So we can have bleeding and all those other issues associated with lacerations. Now, the punctures are usually like something that penetrates. It's a sharp. Something sharp that goes through the skin. So they are different from just simple lacerations, and they can actually damage a lot of tissues. Now, a little bit about wound healing. You know that there are four phases of wound healing. You have exudative phase, where there's a lot of inflammation going on, and and there's the exudates happening, and there's you get discharges and everything in that phase. And you get resorptive phase where you necrotic tissues and other debris are resorbed into the body. If you are technically haven't removed anything on the wound, the body will do it, and that is the phase that we call it the resorptive phase. And then the body need to rebuild what is lost. We call it the proliferative phase, where the proliferation happens. Then the organ or the tissue structure needs to be regenerated from what has happened. So these are the 4 phases that you will see. So I just want to show this. This is a very, very complex process. It's not like some cells just get lost and some then just get closed up eventually. So there are a lot of what we call chemicals involved in these processes. So all these things, it's an amazingly complex process where you can see how the epithelial cell starts migrating from the cut end and under it, and there is a scab over it, and it is protecting this area. So, and macrophages, and also there can be an infection, so the infection has to be fought off, and there's so much more happening in these small wounds. Of course, this is another area where you have a lot of granulation tissue happening, and over the granulation tissue, the epithelium starts migrating. So these are different types of wound healing, where that was the primary wound healing, where there is not much of a dermal loss, and dermis is intact, and where only the epidermis has to grow over it. So these are primarily healing. We need to know that why there is a scar. Epithelium doesn't scar at all. So we need to know that only the mesoderm undergoes scarring. So mesoderm is the precursor. Mesodermal damage is the precursor of scarring, simply because mesoderm cannot replicate itself to the normal structure, because it doesn't have the scaffolding. We call it scaffolding. If you have the scaffolding, actually it has the ability to regenerate. We'll talk about this point later on, where there's new developments. For your additional knowledge, I will talk about that a little bit later. Now, these are the secondary injuries where there's dermis also damaged, and dermis needs to be dermis is actually replaced with granulation tissue, and eventually they will be replaced with scar tissue, where the collagen will fall down, and you will see a scarred bed, and it will not look like a normal skin. Now, primary wound healing is a very important thing, where when you see patients at primary care level, where if the patient comes to you after a surgery, it may be I'm just going to give you some examples from plastic surgical arena, where you will see some primary wound healing is the most important thing, where you cut a person and you get the wound to heal primarily with a linear scar rather than a big patch of scar. So the classic example is in plastic surgery. You might see this, and it's a breast lift. What we call is a breast lift. You might see this. The skin needs to heal pretty well, otherwise the patient will not come to us at all. I mean, if you see a scarred bed, and this is after healing, and there is a lot of scar therapy to undergo. And this little kid also has the same issue. This drooler came to us with a cleft lip, and you can see the amount of tissue that we have replaced and reconstructed to give a beautiful upper lip and a nose. And you can see the nose is also wonky, and lip is also gone into. It was going up into the nose, and finally, when you get it, and you need the wound to come together beautifully, and you don't want this scar to show after surgery. So there are a few techniques that we do to get rid of the notion of a scar, and we hide the scar in a normal, what we call as a philtrum. So these wounds need to heal primarily. So if you get this wound like this, the dressing is a simple dressing. Now we have advanced. We have advanced in wound dressings, in primary dressings, that we have what you call a soft tape on soft cloth. It's a soft cloth tape, so it can be sterilized and put on wounds, and you don't need any gauze or any other elastoplaster or anything. You don't need it. It just does and it's also sterilizable, so they're very good for the wounds. So these are the ones that I'm going to talk about it and show you later on. Now there's another interesting area where we need to understand some of the principles behind classification of wounds. Now this is another classification depending on the outcome. So we want to know whether this wound is going to be a happy story at the end. If this needs to be a happy story, you need to make sure that the wound doesn't undergo any problems, then you will see the end point that you want to see. You want to see a beautiful breast after breast lift or a breast reduction. You want to have a class 1 wound where the wounds are clean, uninfected, no inflammation is expected. So minimum inflammation is expected, and it's primarily closed, and it undergoes minimum amount of scarring, and they hardly need any antibiotics or anything. So, and you don't need dressing changes, frequent dressing changes. One dressing change is enough, and you will see them after about 1 week, or sometimes after about 2 weeks. Sometimes, especially in children, we see them in after 2 weeks. So you don't need to open the wound and trouble the wound again. Now, with class 2 wounds, usually they are clean contaminated. You might know that these all have a amount of what you call risk of getting infected. So they are getting open to respiratory tracts, elementary GI tracts, genital tract. So but they are usually happening, although they are opening into these colonized tubes. We don't expect them to get infected. So we actually clean it properly, and we get the wound to approximate properly, and then we have dressings that can eliminate the risk of getting bacteria from out.
So this is very important to know. So the clean contaminated wounds does have a risk factor. So sometimes we look at them little earlier than usual wounds, especially sometimes we keep them open. Now, class 3 are generally fresh open wounds that all of you might get them, and you might get these wounds after a RTA, maybe after a fight. They as we say now, nearly the national sport of Sri Lanka has become assaults and sword fights, where we get, if you know the amount of sword fights that we see in the national hospital, they get chopped, they chop each other, and it's almost like it's a medieval type of a period. You see people cutting each other and coming into the accident service, and no wonder to waste our precious national resources. And these are actually contaminated wounds, and these are open to outside, and they get colonized with, say, various things when the time goes on. Especially these can get infected, and unless you do a thorough cleaning and repair of these earlier, they can get infected. So inflammation, usually they undergo inflammation, and they have a risk of sort of an unwanted result. Class 4, which usually the road traffic accident, where you have a lot of dirt and the contaminants on the wound, and also a lot of dead tissue. Typical results from the RTS, as I mentioned, and they have a lot of microorganisms. However, they can also cause infection, especially even going up to they can go up to gas gangrenes and all those bad things from a simple wound infection. Okay. Now, we'll talk a little bit about acute wounds. As you can see, this is an acute wound of a nail bed. Now, these things are very important. There are some principles that you need to follow. I will just walk with you with these wounds, and what are the basic things when you want to assess a wound. Now, this is an abrasion. You don't know that this abrasion will heal spontaneously. So you just need to have a barrier against bacterial infection. So a bacterial infection can occur in this dead tissue, where if you have dead tissue, you might need to remove them. Otherwise, you can get infected and can undergo suppuration. And so usually these patients will have a problem like scarring is the biggest problem they will have, and they will have questions: how long will it take to heal? Of course, in an area like face, we generally estimate about 1 week, and other areas sometimes 2 weeks. So an ointment, a barrier ointment is enough. Even paraffin containing ointments or aloe vera containing ointments, aloe vera are usually much nice. I think aloe vera will be a very good option, especially if they are prepared, freshly prepared one, not the freshly prepared one, but actually commercially prepared one, because you need to remove the chance of getting the sap contaminating the aloe vera. So you need to take it. You can't just chop up aloe vera plant and put it on your wound, because it's not advisable, because you can get a skin reaction to the sap, and you can have an allergic reaction. So there is a way to do it, and there are people who are doing it, and there's aloe vera commercially available. It's a Sri Lankan product, so you can use it. There are Sri Lankan products, and Sri Lanka is producing enormous amounts of aloe vera these days. So feel free to use a commercial product. And so we'll move on to another area where these are actually excoriation, not a tear. Sorry about that. So the tears can occur. These are cat scratch, and these can leave a bad mark, especially in our skin, where you get very ugly linear scars. So better to advise them and tell them in advance. These are not tears, but just forgive me for that error. These are excoriations due to cat scratches or maybe dogs. And these are tears. These are tears. This is actually torn upper lip. Remember this in an area where all the tissues are usually present in a tear, and there's a type 1 tear, and if they are there, you don't remove them. Try to reconstruct using whatever the things are available. Now, lacerations are something like this. It's getting jagged on with something very heavy or falling on there, and just torn the skin. So it can actually tear a lot of tissues, but you need to assess the patient before surgery or before any treatment. You need to see if it is a hand. You need to know whether there are nerve injuries or vessel injuries or blood circulation is intact. Very important to note them and refer them appropriately. If the patient, you are not examining the patient, and the patient says after surgery there is numbness in the finger, of course you will not have an answer if you have not examined earlier. So better to examine all hand injuries with regard to sensation as well as blood circulation. Easier thing, circulation, is the capillary refill. You just check the capillary refill and sensory. If there's any defect in the sensation, always have to note it down and tell the patient, look, there is a nerve injury that needs to be treated earlier. Now, these are degloving injuries. I'm not going into detail about degloving injuries. So degloving injuries are very bad, and this is a scalp injury we have replanted. These are not just sutured. Blood vessels needs to be anastomosed, and a lot of things have to be done. And usually they don't end up very well. Although we do replants, they don't do very well, because the amount of blood circulation in the scalp is enormous, and a lot of venous issues are there. Of course, stabs are very rare in Sri Lanka. We have stabs on the other areas also, not on the face though. I have not I have yet to see a stab on the face, maybe cuts, but not really stabs. So now we move on. Now we talked about wounds. Now we talked a little bit about wound infection, and you need to know some basics about wound infection rather than just going into straight away going into management. So there are a few definitions that you need to know. What is a contamination? What is colonization? What is a topical infection? And what is a local infection? And what is cellulitis? And what is sepsis? So these are all defined things. So you need to know what do you mean by that. So it's a universal language. It's a universal language where you see bacteria. If it's just a contamination, the bacteria is there, just there. They're not going to cause a big problem. And the other thing is when it's colonizing, that means the bacteria is dividing, and it doesn't cause a problem for the patient. And tropical infection also, there is some increasing varieties, and they are secreting some biofilms, and this is called critical colonization, where there is now this is trying to get into the tissue, and there's a lot of tissue getting prepared for an infection basically. So local infection is something that you see and treat. You can be treating with local antiseptics. Till that point, you should be able to treat with antiseptics alone. There's no infection. However, when there's biofilm, the antiseptics might take a little longer to act, and you might need to use a stronger antiseptic, as well as you might need to do a limited sort of a thorough debris removal over the superficial area, where you have to physically remove the biofilm. Otherwise, your whatever you use will not penetrate into the bacteria because there is a biofilm. Now, local infection, of course, there is a chance. How do you start treating local infection? Local infection, you must always diagnose what is the bacteria. If you know your pattern in that area, that is fine, and you can start with a very basic antibiotic, and then you can go on looking at the wound, and if the wound becomes better, and then you can actually get the wound to heal. But otherwise, if there is evidence of local infection, always better to go for a culture, because then the patient will be unnecessarily spending money. Now the antibiotics are so expensive. It will cover 1 day's, if you give 1 day of antibiotic, will cover the culture cost basically. So if you give maybe 5 days, 7 days antibiotics, without a culture, it will be, you need to, I'm sure you can work out the maths there. Now, and also if you are giving an antibiotic that is not really relevant to that bacteria, and it's not going to end up in a you are not going to give antibiotic that is good for a gram-positive bacteria, or you should start giving gram-negative bacteria. They cover antibiotic that covers gram-negative bacteria. So these are the other things that you need to think of. This is where your knowledge comes into play, rather than you are not a technician that you will say this wound, this wound, this one. It's not like that. You have to judge. Clinical judgment has to be utilized. Now, antiseptics, I'm not going to deal with lot of antiseptics, but the main thing is, if a wound is infected, you don't need the cleaning is generally done with soap and water first. So that is one of the best ways to get rid of the bacterial load from a wound. So running water, soap is quite it has been shown over and over again. Wash it very well, and then it will reduce the bacterial load, and it's you don't need to use lots and lots of antiseptics to get rid of bacteria. Now, coming to antiseptics, what are the antiseptics that you can use in a sort of a so we talk about wound cleansing first. So this wound cleansing is the one that you are talking about. It removes debris and devitalize tissues and remove, if the patient had a dressing, and remove the dressing residue, because sometimes dressing may be adherent to the wound. Now, remove excess and drying crusting exudate will take a little longer to remove because it needs to be soaked well. So you don't be in a hurry to do these things, because you want the good end result. So maybe use ask the patient to keep it exposed to water for a longer time, and running water, and so they get the dry crusting soaked, and you should be able to remove it gently without causing much pain. Now you can use this is actually the guidelines, but fluid should be warmed you don't need to do that in our country because it's already warm, and our water is quite if you can drink the water, you can use it on a wound. If you know that if you are drinking that water, be sure that it's safe to use in a wound. So that's a basic rule in wound cleansing, using water. So I'm sure that you are not going to drink contaminated water, so you will be using clean water. Use that water to clean the wound. So that is good enough. And the other things are remember, don't use alcohol on wounds, acetones, and antiseptics are not really required on a infected wound. So you don't think of povidone. I'm just going to talk directly. There's no point using povidone or iodine on a wound, because basically iodine gets inactivated as soon as it come into contact with the organic matter. That means povidone iodine is only for skin preparation for surgery, or skin preparation. That means intact skin. If there's any organic matter on the skin, if you use povidone iodine, it just gets inactivated. It's just that it looks nice to have a yellow color skin, rather than you are not going to achieve anything. So and it's 25,000 times less potent than I think 20 times less potent than chlorhexidine. So if you use chlorhexidine, that will give more wound cleansing power, antiseptic power, rather than using povidone iodine. Chlorhexidine comes if you are investing in a antiseptic for your practice, make sure you get a effective one rather than getting an ineffective. You will see this result as soon as you change over to better antiseptic. Now there are very advanced antiseptics also there. We have sodium hypochlorite, that is Milton solution. Now there are buffered Milton solutions available in the market. So they are very useful, but you can't use it forever. It can be used for maybe a couple of days. After that, you have to throw it away. Otherwise, it gets turned into water. So it doesn't really work. So remember that if you are using them, use them vigilantly. And there are other very advanced wound preparation are also there. If there are patients who can afford it, or if you want to have a sort of a very standard and a very big wound care practice, I recommend you to go for a sort of a multi-dose wound antiseptic solution, but you need to make sure that it's been tightly closed and kept in a recommended environment, rather than if you keep it in sun, it just gets destroyed, and if it's very heated up, it gets destroyed. And you need to make sure that what you are investing is going to be useful at the end. So antiseptics, when you talk about antiseptics, these are the antiseptics. The cheaper antiseptic for getting rid of what we call a Pseudomonas colonization of the normal skin. Of course, normal skin you can use alcohol. That means the cheaper one is what we known as the isopropyl alcohol. So you can use isopropyl alcohol to clean the surrounding area, not the wound, surrounding area, if you think the wound is getting colonized with some bacteria like Pseudomonas. And so the acetic acids and those things are all were there. I mean, they are going out of practice because the acetic acid, what you get as acetic acid may not be acetic acid next day, because it just gets, the acidity just goes away and you don't need to use like vinegar on the wounds. It doesn't have, this era, you should be practicing safe medicine, and predictable things should be used on patients rather than taking a bottle of acetic acid that was prepared 1 month ago on a wound. So you shouldn't do that. It should be a freshly prepared one if you're using those things. Now I'm not going to, this is the how to do it, how to clean the wound. I'm just going to show you that, you can get some gauze swabs, and you can actually remove a little bit, but make sure that you don't leave these gauze piece particles and those things on the wound. They are very good media for colonization. Sorry. Now dressings needs to be I know for sure that dressings are not the knowledge about dressings are not taught in medical schools. So these are what you have, maybe you have seen your internship when sometimes a medical representative might have talked to you about some dressings and you think that is the best thing, and I'm sure that most of not even surgeons are taught in this until recently, the classification of dressing types and those things. So how do you decide on a wound dressing? Now you need to decide on a wound dressing. So it's not always cotton, gauze and crepe bandage, each and every patient. Now, and there's no dressing is suitable for all wounds. So you need to have a wound matching the wound. So you need to know what are things that So it should be able to maintain a moist environment on the wound dressing interface. So what do you mean by moist environment? So it's been proven all over the world that wounds needs to be for a wound to heal, it needs to be moist. So dry wounds, if you think the wound is dry, a better wound, but then it's where usually a patient with a ischemic limb, we should heal. It doesn't heal because it needs to have the cellular processes to go on. I showed you how many cellular processes are involved in wound healing. So all these chemical mediators to act, the cells to act, you need a moist environment. So these are cells that are migrating. We are not like made out of plastics. We are made out of cells that are living and breathing and moving and dying also. So and desiccating and getting absorbed. So we are multicellular organisms. So we think that we are just one person. We actually is a clump of cells which is together and doing some trying to live till the expiry date. So there's a production date and expiry date. We just it's a clump of cells that it changes and just one fine day just can't be together and just vanishes off. So so this is so you need to allow these cells to do its job. So but if there is excess exudate, you might need the dressing to do the job. You need to remove the excess exudate from the wound. So otherwise it becomes another problem when there's too much of exudate. The bacteria will be there, and there's going to be a lot of soakage, and skin going to be surrounding skin also going to get damaged. Now it should not stick on the wound. If the dressing gets stuck on the wound, then it's going to cause another problem. The patient is not going to come to you for sure in the next round of dressing, because it's going to cause a lot of pain when you are removing. And it should protect from the external environment. Basically, it should not allow bacteria to come in. So whatever the bacteria, you cannot get rid of bacteria, because we are living with bacteria, we are breathing with bacteria, we are eating with bacteria, we are doing everything with bacteria that is originally on our body. So we cannot be sterilized basically, in another sense with regard to bacteria. So we need to prevent external bacteria coming into the wound, and also it needs to adhere to the skin. You can't have a patient who is who walks out of your clinic or the dressing area and coming back saying it's on the road, I need another dressing. So it shouldn't be like that. Now there should be the severity of the dressings is very important. So, and also it keeps the comfortable, give them comfort, and it needs to be cost effective. You can't have very expensive dressing on a small area. So I'll show you about some of the dressings which are very expensive and which should not be used on simple wounds. And when there is diabetes and you risk of infection, you don't put a bulky dressing that is about 3-4 centimeters thick and and try to try to get them down in about 1 week time. So, but you need to have frequent dressing changes, and some other patients like diabetic foot diseases. And it should not be toxic, basically, it's understood. Now, there's 4 types of dressings. You get a primary dressing that directly go on the wound, that we call a primary dressing. Now, what is a secondary dressing? Then, means if there is a primary, there should be a secondary. So, secondary dressing is something that covers the primary dressing. Very easy to understand. So, you need to, if you want to purchase dressing types, you need to have your primary dressing set, and you have to have your secondary dressing set.
And these dressings can be the other type of dressing is the occlusive dressing, where you have one dressing
and it just occludes everything, and it does not allow anything to go in. So these are very these are important in certain aspects. So you should not be using them in an instance where you want the wound to actually get oxygenated. This is what called semi-occlusive dressings, where some of the oxygen and moisture vapor to evaporate. So there is some amount of breathing that is happening through these dressings. So these are the 4 types of dressings that are available currently. So what do they do? I'm just going to go through very quickly. What is a dressing's job? So it just absorbs. It absorbs like so wicking or the capillary action, and it allows certain bit of evaporation and transmission. So these are actually graded. So when you know this wound needs this amount of evaporation to happen, you will select that dressing. And also you have fluid retention. If you want fluid to keep there rather than just this pour over, so you have certain ingredient that absorbs moisture and keeps a moist environment, especially areas where there's frequent drying of wounds. So you need fluid retention on these wounds. You don't want any drying of excessive dryness on the wound. Now we'll move on to some of the dressings that are available. Now these are synthetic fiber. I'm not going to talk about gauze, the cotton gauze, but these are synthetic gauze, and they create remember these things also create a dry wound. And you have island dressings. These are called island dressing, where you have an absorptive center and a secondary dressing already in place. So these are island dressings. So I have put some of the trade names also. You can actually you will know them better since they are very commonly used. And so how to make this at home? How to make this island dressing at home? That's one of the areas that I am going to talk about. So this soft cloth liner on tape is actually freely available, and you can actually put a small piece of gauze and use the soft cloth liner around the wound. So the soft cloth liner can be sterilized, or you don't need to sterilize it if you don't have a facility to sterilize, or get some there are places that sterilizes these things. Of course, if you have gauze that is sterilized, you just put the gauze on the sterile gauze on the wound, and you can put the dressing on top of it. So this is like any other elastoplaster, but the best thing is this contours very well to the wound, and it sticks very well, and it doesn't cause allergies and doesn't leave gum residue on the skin. So these are advantages of these newer island dressings, and you can make it at home also, so it's not a big problem. So semi-permeable ones are also there. They are very commonly used at the moment. They are very they are sometimes they are expensive, but I think they are available all over the country now. You can use them, and there are cheaper ones also coming into the market. And if somebody want to invest in producing these in the country, you are welcome to do it. At the moment, I don't think there's anyone doing this. Probably these are very lucrative markets. Right, now tool dressing, where you have we call it commonly called Vaseline gauze, but Vaseline is a trade name. But these are tool dressings where you have paraffin impregnated dressing. So it just it adheres a little bit, but not as bad as gauze on a wound. So these are used for big areas, especially like burns or frictions or large areas that you need, or a donor site of a skin graft. These can be used on these wounds. So now we have impregnated with antiseptics or antibiotics. So there are couple of tool dressings that has antibiotic impregnated, especially fusidine impregnated ones, and also clohexidine impregnated as tool dressing. So these can be used on infected wounds after cleaning, or contaminated wounds, and also burns. Burns, of course, it has proven that the antiseptic containing dressings have a slight advantage over plain dressing. So it's because the burns behave differently than normal human other wounds. Remember that the other important thing is that these needs another secondary dressing and also retaining dressing. Now these are non-adherent dry dressings that absorbs a little bit more than just gauze. So these are available also. These are actually synthetic ones. And there's alginate dressings. These are actually these are polysaccharides from seaweeds. You will see them quite often used in cavity dressings. There you just pack these things, and then they form a gel and produces a sort of a moist environment for wounds to heal. And these are foam dressings that we commonly use for bed sores as early bed sores. That means grade 1 bed sores, and sometimes on areas where you don't need any adherence, where there's very painful areas, you use them. Our common practice is grade 1 bed sores. So these hydrocolloid dressings are also, there are wound hydrocolloid dressing that sticks into wounds. You can use it for, they are waterproof and also keep the moist environment. So they are used for smaller burns and donor sites, that sort of thing. So very easy to, and very conforms to the wound, and very patient friendly. Now hydrogels, I'm sure that you have used hydrogels on a regular basis. I'm sure that you have seen a lot of wounds being treated with hydrogels, and these are actually quite good, and especially to keep allow the chemical sort of the debridement, not a mechanical debridement, but an enzymatic debridement. This promotes enzymatic debridement of wounds, and just go on and promoting wound healing and granulation tissues. So these are very good for granulation tissue formation. Now these are hydrofibers. These are newer fiber material where there's, if you want a less amount of gel, but a controlled gel environment, you can use these things. So they are a bit expensive, but they need secondary dressing as well. And these will not be useful for wounds that are that needs a lot of moisture, So now these will come into Sri Lanka very soon. These are actually sodium chloride infused wound dressings. So these are quite good. That's why we are now more this is actually they have used our knowledge where we are now using saline dressings very often. If you want to get rid of some necrotic material without causing pain to the patient, so the patient doesn't need to go to theatre, so small amounts. So this slough can be actually be removed with saline dressings twice a day or once a day quite easily. But these things can go on the patient. They can last for about 3 days, and these will pull the slough from the wound. So it creates these are called sodium chloride containing dressings. So these are new dressings that are coming into practice, and they are very not that expensive also. And you have seen this collagen. You will be knowing some of these things can be used on burns. I'm just putting this up because the collagen, when you are applying, it has to be done on a fresh wound, not on a burn. If you put this on burn tissue, it doesn't give you any advantage. It's just another covering. So if you want to get the proper advantage of having collagen on a fresh wound, you have to actually what we call burn scrub. You need to scrub the burn and then put it. So this is important. Scrub the burn before you put collagen on wounds. Scrub the burn before you put collagen on the burn. And there's no point putting them on full thickness burns or deep dermal burns. You only put them on superficial burns and epidermal burns, superficial burns, and some mid-dermal burns, not all mid-dermal burns, but you need to take them to theatre and do it. Otherwise, you have to give if it is a small area, you give local anesthesia and do it. Otherwise, the collagen effect is not there, and it's not going to stick on the wound. Now, I didn't want to touch on the silver dressings, and because we are talking about primary care. Silver dressings should not be used in primary care. Basically, they are reserved for burns now because it's very expensive. Sri Lanka does not produce silver dressings, and we should not be using these because they are effective. Yes, they are effective. But if you start using them for these small dressings that can heal without what we say is even if you apply cow dung, some of the wounds will heal. So there's no reason for use silver dressing on those things. So you are going to waste a lot of money on foreign currency on these things if you use things inappropriately. So you can impress the patient by some other way, but don't impress by just playing stupid. So don't use silver dressings on wounds other than burns at the moment. So we are not that rich. So now the wound assessments. Now this is a very quick guide to wound assessment. Now there are non-draining wounds and draining wounds. That means there's something needs to be draining, and there's granulation tissue and the necrotic tissue is there. So these are the goals. Just take a snapshot of this one, just go through it and see but it makes sense, right? So in a nutshell, what you do is, so the draining wounds and there's granulation tissue, you need to protect the wound and also protect the wound surrounding area. So you need absorptive dressing and also a dressing that occludes from moisture that is draining into the normal tissue. Now if there is necrotic tissue, you need to have something that can actually do some enzymatic debridement and then clean the wound itself. Now non-draining wounds, so you need to have moisture and occlusiveness. So you need to put moisture in non-draining wounds, and so the other one is the necrotic non-draining wounds. They are actually dead and dry wounds. So you need to actually moist them up, use colloids and get the balance of moisture, and then let it separate. The necrotic tissue will separate, and then you can remove it, and then you can do the other dressings. That is what you should be doing. Now acute wounds and chronic wounds. What is chronic? I put this slide to just say why it's a chronic wound and why this acute wound becomes a chronic wound. just because the healing process is stuck in somewhere. It may be due to nutrition issue or blood supply or infection or something like that. So that becomes a chronic wound. So you need to identify why it has become chronic, what is the reason for it to become chronic, and you have to reverse it, rather than just trying something, putting on top of it every time the patient walks in. You have to reverse what has happened that is causing the healing issue. Now you need to describe what, if you describe a wound bed, you have granulating wounds, epithelializing wounds, sloughy wounds, and necrotic wounds and hypergranulating wounds. I am just going to show you some of the pictures. This is nicely granulating wounds. The granulation, if it is healthy, it's called a pinhead size. Pin is that, the alpenether, that the head of the alpenether is actually equal to one of these fresh granulation. It's good granulation. Now these are hypergranulation. You see abnormal size granulation, that this is a lot of colonization, and it could be critical colonized, or it could be going into early cellulitis, if you can see the surrounding edges. Now these are sloughy wounds, and that needs to be that needs a lot of enzymatic debridement. If you are not, because the surgery is not going to give them a better outcome. Even granulation, the simple enzymatic debridement would be adequate in these cases. This is a dry gangrene, or this you need to wait till this falls off, or you need to sharply cut this off and get a fresh wound to apply. Other moisturizing wounds, otherwise you can just put a dry wound and you apply a sort of a what you call a barrier cream around the wound edge, so it prevents bacteria getting in, but you need to change it regularly, so till this falls off. Now these are epithelializing wounds. I just want to show you epithelializing. You can see some of the pale pink epithelium happening, and you should not use something like hydrogen peroxide. Hydrogen peroxide is not a good wound irrigation or antiseptic. It just produces foam, and you love to see foam, but no, it's not going to help the patient. Yes, and it smells awful also. If you just put on this one, the cells will die, because it produces a lot of heat and a lot of oxygen moieties, and it will damage the newly formed cells. Now just a little bit on discharge. Wound discharges are there, but discharge is not a bad thing. Remember, if there is a good discharge, that means the wound is actually healthy. So it contains a lot of growth factors, and promotes epithelialization, as I told, that the cells just move across in a free moist environment better than a dry environment. So you need to know about the type, amount, and the smell. And also the color. So this color, if you get a lot of color changes. The serous one is what you call is a normal thing, and you get hemoserous where the clear pink, it's also normal. But if it is increasing, that may be, there may be a cause. It may be due to infection happening. So this is serous sanguinous, so the blood red color ones. Usually there is some trauma, or there is some damage to granulation tissue happening. Purulent, of course, there are different colors. Yellow or yellowish white. That means it's usually Staphylococcus, and it could be Streptococcus also. But gray is usually we call it the coliforms, proteus are usually gray, but the smell is different. If it's green, usually it's Pseudomonas, and it has its own characteristic smell as well. So just some of the examples. Now last, I'm sure that you have probably had enough with wound care, and might just have given up wound care also. I'm not sure, but I hope that you will practice some science when you practice wound care. So this science involves scar therapy. So remember, the patients, every dermal damage will leave a scar. So scar needs to be managed, otherwise the function will go off. Especially when the face, you need to have a scar therapy. to get a better idea. So you mold the scar to get the best scar for that patient. So that is the whole idea about scar therapy. So I think I have covered a lot, and I've covered from basics to advanced management of wound during this hour. I think I'm 1 minute short of 1 hour, so so 59 minutes. I hope I have given you some insight into making a better practice, and also for you as well as for patients. I would like to thank the organizers and especially the GMOA for giving this opportunity for me to give this information. So giving me the opportunity to talk to you, and also to improve the patient care level, as well as moving into the next level of medical practice, rather than just going into practicing medieval type of surgeries or wound care.
Thank you very much, sir, for that interesting and very informative lecture. And I have one single question. How does the nutrition works on wound healing? Can you please discuss about that?
So yeah, especially when you come to a general practice, the problem is the nutrition matters mostly in patients who are bedridden, and patients who are not taking adequate nutrition. So the nutritional factors, of course, as you see, if the wound is big, an amount of energy that is needed for these cells to replicate and synthesize new proteins, and doing all these things needs energy and protein. So we need to actually look into their nutritional aspect, especially the bedridden patients with bed sores. You get bed sores quite often, and they need a lot of nutrition. And burns, of course, burn wounds need double the amount of proteins. That's another factor.
Thank you very much, sir, for that interesting lecture. And it comes to the end of today's session. Thank you for joining, and I hope to meet you in 2 weeks' time. Have a good day.